All right, so let's get started. My name is John Scher. I'm one of the PGY1 pharmacy residents here at Stony Brook University Hospital. Today, I'll be presenting Calling the Shots, a focus update on GLP-1 receptor agonists. So disclosures, there are no financial disclosures or conflicts of interest with the presented material. Brand names of products in this presentation may be included for identification purposes only. So the objectives today is to, one, review the mechanism of action of GLP-1 receptor agonists, compare dosing, administration, and clinical effect of currently available GLP-1 receptor agonists, identify adverse effects and contraindications to use associated with GLP-1 receptor agonists, as well as to evaluate the literature supporting the use of GLP-1 receptor agonists for cardiovascular and metabolic benefit. So just a background, 34.2 million Americans have diabetes. That's just over 1 in 10. The total direct and indirect cost associated with diagnosed diabetes in the United States was $327 billion in 2017. Atherosclerotic cardiovascular disease, abbreviated ASCVD, is the leading cause of morbidity and mortality in patients with diabetes. And obesity is a leading risk factor for type 2 diabetes. So what are GLP-1 receptor agonists? So before I get into the pathophysiology of the drug, I just wanted to introduce you guys. You may have seen some commercials on this, or it might be something you're familiar with via practice, but GLP-1 receptor agonists stand for glucagon-like peptide receptor agonists type 1. And the nomenclature that's common between these drugs is they all end in glutide and exenatide. So getting into the pathophysiology. So GLP-1 is a hormone that's secreted by ingestion of nutrients in the small intestine and colon. This image here, we have a magnified intestinal villus with an open L cell shown at the lower left of the image. GLP-1 diffuses across the basal lamina into the lamina propria and is taken up by a capillary where it's broken down by dipeptidyl peptidase 4, abbreviated DPP4, which is located on the luminal surface of the endothelial cells. So approximately 25% of the secreted amount reaches portal circulation. Then the liver further reduces the amount, approximately 40 to 50%. So approximately 10 to 15% of this hormone enters your circulation and reaches the pancreas and the brain via the endocrine system. In the pancreas, they bind to receptors on the pancreatic beta cells and stimulate the release of insulin, which works to maintain euglycemia. So there are two hormones that are secreted when you ingest food. They're known as incretins. So these two incretin hormones are glucose-dependent insulinotropic polypeptide, abbreviated GIP, and your glucagon-like peptide, which is your GLP-1. They're secreted by the gut after food consumption. Together, they're responsible for the incretin effect. They bind to receptors on your pancreatic beta cell and stimulate the release of insulin, which works to maintain euglycemia. Research has shown that in patients with type 2 diabetes, the action of these incretin hormones is diminished. And in the case of GIP, it has almost no effect on insulin secretion. Although the effects of GLP are somewhat preserved, the insulin response is significantly reduced in diabetic patients. Therefore, the therapeutic benefits of incretins have been a mainstay and focus on research and developing new drugs to target the disease. In this image here on the right, you can see that in a healthy patient, they have a normal incretin effect, whereas in a type 2 patient, this incretin effect is significantly diminished over time. So the actions of GLP-1 in target tissues. So GLP-1 has a number of potentially beneficial effects in the setting of type 2 diabetes. The effects of exogenous GLP-1 observed after administration of patients with type 2 diabetes includes decreased glucagon concentrations, improved insulin sensitivity, decreased A1C, slowed gastric emptying, increased satiety, decreased free fatty acid concentration, and decreased body weight. The effects of increased glucose uptake and glycogen synthesis in fat, liver, and muscle cells is associated with indirect effects of insulin release and decreased glucagon release produced by the GLP-1 exogenous hormone. So as you can see in this image, the GLP-1 can exert its effects on a wide variety of organs. So in your brain, it can cause neuroprotection and decrease appetite, increase satiety. In your heart, it's known to be cardioprotective and increase your cardiac output. In the stomach, it slows down gastric emptying. And in your islet cells in the pancreas, it initiates insulin biosynthesis, beta cell proliferation, and decreases beta cell apoptosis, which is a common theme in diabetic patients. And in the liver, it decreases your glucose production and increases insulin sensitivity in your muscles. So this leads us to our first question. Which of the following statements is true regarding the hormone GLP-1? A, it's a hormone released from the pancreas that enhances insulin secretion, so it leads to hypoglycemia. B, it's a hormone released from the GI tract that enhances insulin secretion in a glucose-dependent manner, so it has a low risk for hypoglycemia. Or C, it's a hormone released from the kidney that delays gastric emptying and increases satiety, which in turn lowers blood sugar values. Yep, perfect. So the answer is B. It's a hormone released in the GI tract that enhances insulin secretion in a glucose-dependent fashion, and it has a low risk for hypoglycemia due to this glucose-dependent manner which is released. Okay, so just an overview of the injectable glucagon like peptide 1 receptor agonists. So we have 6 marketed GLP-1 receptor agonists on the market currently. So you have your dulaglutide, brand name Trulicity, which is dosed weekly, your exenatide, which is your brand name Byetta, which is given twice daily before meals, your exenatide ER, which is the extended release version of exenatide, brand name Bydureon, which is dosed weekly. You have your liraglutide, brand name Victoza, which is dosed daily, your lixisenatide, brand name Adalimumab, which is dosed daily, as well as your semaglutide, brand name Ozempic, which is dosed weekly. While all of the GLP-1 receptor agonists mimic the activity of GLP-1, they all differ by molecular size, duration of effect, pharmacokinetics, and ability to penetrate different tissue compartments, their dosing intervals, their A1C lowering abilities, and they have different effects on the glucose profile, whether it's fasting glucose that it predominantly affects or postprandial glucose or both. And the frequency of adverse effects is also varied in between these drugs. So it's something to know. So there's different types of glucagon-like peptide 1 receptor agonists. You have your human GLP-1 based receptor agonists, as well as your exendin 4 based receptor agonists. So the first GLP-1 receptor agonist was introduced in 2005. It was isolated from this guile lizard, which is a species of venomous lizard native to southwestern United States. And like a systemic investigation of the composition and activity of the lizard's saliva and venom led to the isolation of this exendin 4, which mimics GLP-1 through stimulating the GLP-1 receptor. The exendin 4 has a 53% homology to native GLP-1, and because of this structural similarity, it's able to bind to the GLP-1 receptor in vivo and results in glucose-dependent insulin secretion, essentially restoring what diabetic patients lack. And then in regards to your human GLP-1 receptor agonists, their homology is exceptionally similar to the native homology of GLP-1. So they're, instead of 53%, which you can find in exendin, the GLP-1 homology is upwards of 90%. And those are your brand names, Victoza, generic liraglutide, Trulicity, generic name dulaglutide, and Ozempic, generic name semaglutide. So just considerations of the drug class. So dosing and usage considerations, there's an increased side effect with renal impairment. Exenatide is not indicated when a patient's eGFR is less than 30, and lixisenatide, there's caution when a patient's eGFR is less than 30. A common adverse effect of the drug class include GI side effects, namely nausea, vomiting, and diarrhea, as well as injection site reactions and a risk for acute pancreatitis. There's also a consistent black box warning with the majority of GLP-1 receptor agonists, where it's contraindicated in patients with a personal or family history of medullary thyroid cancer or multiple endocrine neoplasia syndrome type 2. So just looking into this black box warning a little bit further. So the black box warning recommends that patients be counseled on the potential risk for medullary thyroid cancer and the symptoms of thyroid cancer, as well as the contraindication in patients with this personal or family history of medullary thyroid cancer or multiple endocrine neoplasia syndrome type 2. And if you look at the mechanism, the parafollicular cells, which are your C cells, they're like the neuroendocrine cells in the thyroid whose primary function is to release calcitonin. And in medullary thyroid carcinoma, originates from these C cells. The functional effect of GLP-1 receptor agonists on rat C cell lines was investigated in a study, and they found that GLP-1 receptor agonists elicited calcitonin release and calcitonin gene expression in a dose-dependent fashion in rodent C cells. And GLP-1 receptor agonists, including your native GLP-1, as well as exenatide and liraglutide, they also activated your rodent thyroid C cells to release calcitonin in a GLP-1 receptor dependent fashion. So how to administer the drug? This is just to know if you ever have to counsel a patient. It's a subcutaneous injection that is preferably given on the back of the upper arms, the stomach or thigh. And some devices include a pen needle, some do not. So this is something important to look out for, especially in like the community setting. You don't want to give a patient a pen needle without a pen without a pen needle. It's useless. And some devices require reconstitution or priming prior to injection. So it's a key counseling point. So it's place in therapy. So we'll look into the ADA guidelines. So the ADA guidelines recommend that you initiate therapy for type 2 diabetic patients with metformin and comprehensive lifestyle modifications. And then the second line therapy is where the variation exists. So if they have an established ASCVD risk, then a GLP-1 receptor agonist with proven CVD benefit is recommended. If they have heart failure or CKD, then a GLP-1 receptor agonist could be recommended as well. If you need to minimize hypoglycemia, you could use a GLP-1 receptor agonist. And if there's a compelling need for weight loss or to prevent weight gain, then a GLP-1 receptor agonist is indicated. And this is just looking into a little bit further. So if once a patient is initiated with lifestyle modifications and metformin and they have known ASCVD risk, then you can initiate a GLP-1 receptor agonist as combination therapy. Let's say a physician puts a patient on another medication, such as like an SGLT2 receptor inhibitor, then you can, and if their HbA1c is above target still, then you can consider adding a GLP-1 receptor agonist for like a triple therapy effect. If a patient has heart failure and they're put on an SGLT2 inhibitor and either it's contraindicated or if their HbA1c is still above target, then you can consider using a GLP-1 agonist in that case as well. And then if you want to minimize hypoglycemia, since the mechanism of action of GLP-1 receptor agonists are glucose dependent, it's indicated to minimize hypoglycemia in type 2 diabetic patients. If you want to minimize weight gain or promote weight loss, then a GLP-1 receptor agonist or SGLT2 with good efficacy for weight loss is indicated. And then this is just looking at the American Association of Clinical Endocrinology. In the AACE guidelines, agent selection preferences are guided by the initial HbA1c. And so basically, if a patient has a HbA1c of less than 7.5%, then you initiate monotherapy with metformin. But let's say like their HbA1c is greater than or equal to 7.5, then you can do dual therapy with preferably GLP-1 receptor agonist, or if they need further therapy, then like GLP-1 receptor agonist with like an SGLT2 inhibitor. And you titrate the dose accordingly. So as you can see, like in the monotherapy, after metformin, GLP-1 is second line, and the dual therapy after metformin, GLP-1 receptor agonists are the primary dual therapy agent, and triple therapy is also like the most recommended triple therapy agent. So this leads us into our second question. Which of the following is true regarding the place in therapy for GLP-1 receptor agonists? A, for most patients, insulin is the preferred injectable therapy rather than GLP-1 receptor agonists. B, GLP-1 receptor agonists should not be used in combination with metformin. Or C, according to the ADA-AACE guidelines, GLP-1 receptor agonists with proven ASCVD benefit may be the preferred option for patients with this complication. Yep, perfect. So the answer is C. According to the ADA-ACE guidelines, GLP-1 receptors with proven ASCVD benefit are the preferred option for patients with this complication. So just an overview of the drugs. So in 2008, the FDA recommended that all drugs investigated for diabetes should be evaluated for cardiovascular effects, since patients with diabetes have a 2 to 4 times greater risk of developing cardiovascular disease compared to patients without diabetes. So these are the GLP-1 receptor agonist cardiovascular outcome trials, the past and the future. So we'll be overviewing each individual GLP-1 receptor agonist, and then we'll get into the respective study associated with that GLP-1 receptor agonist shortly. So the first drug we'll go over is lixisenatide, brand name Adaligsin. It's FDA approved as an adjunct to diet and exercise to improve glycemic control in adults with type 2 diabetes. Its recommended dosage is 10 micrograms once daily for 14 days. And on day 15, you increase it to 20 micrograms once daily. And the maintenance dose is that 20 microgram dose. The most common adverse effect is GI symptoms, which are most mild to moderate and within the first 3 weeks of starting the therapy, as well as nausea. And then there's also a risk for immunologic antibody development. 70% had like a high antibody concentration and experienced an attenuated glycemic response. This is associated with the Exendin 4 because it's an exogenous form acquired from the lizard. It's not a native GLP-1 that's endogenous to humans. So they might have antibody development, but this does not affect the efficacy of the drug in vivo. So the peak plasma concentration of Adaligsin is 1 to 3.5 hours. The elimination half-life is 3 hours, and the administration is once daily within the hour prior to any meal of the day. And it has a greater effect on postprandial glucose than it does on fasting glucose. So that's something to look out for if a patient is struggling to have their postprandial glucose within control. Adaligsin is a good choice. Also, something to note is that black box warning for medullary thyroid carcinoma isn't associated with this drug in particular. So lixisenatide was studied in the ELIXIR trial in 2015. It was a randomized, double-blind, placebo-controlled, parallel group, multi-center phase 3 event-driven trial with a population size of 6,068 patients. They compared lixisenatide therapy with placebo with the primary composite outcome of death from cardiovascular causes, non-fatal myocardial infarction, or non-fatal stroke. And the results was the primary composite endpoint occurred in 406 patients, approximately 13.4%, compared to 399 patients, or 13.2% of patients in the placebo group, which translates to an adjusted hazard ratio of 1.02, 95% confidence interval with a P of 0.81. So non-inferiority of lixisenatide to placebo was proven in this trial, but not superiority. So that's something to make look out for, that FDA approval is just for the glycemic control of type 2 diabetic patients. It doesn't have that cardiovascular benefit. Getting into the next drug, we're going to go over exenatide, brand name Byetta. It's FDA approved as an adjunct to diet and exercise to improve glycemic control in adults with type 2 diabetes. Their dosing is 5 micrograms initially twice a day within 60 minutes prior to the 2 main meals of the day, and you can titrate it up to 10 micrograms twice daily after 1 month. The most common adverse effects are nausea, hypoglycemia, jittery feeling, dizziness, headache, dyspepsia, constipation, and asthenia. And the nausea tends to decrease over time as the patient gets accustomed to the medication. What's interesting with this drug class is that post-marketing reports show the increased INR with concomitant use of warfarin. So that's something to look out for when a patient is on anticoagulation therapy with warfarin and you're suggesting a GLP-1 receptor agonist. Exenatide might not be the ideal choice given that increase in INR. So the peak plasma concentration of this drug is 2.1 hours. The elimination half-life is 2.4 hours, and it primarily reduces postprandial glucose with a smaller effect on fasting glucose. It's commercially available as a 5 microgram pen, as well as a 10 microgram pen, which provides 60 doses per pen, and you require a separate RX for pen needles. Now getting into the extended release version, which is brand name Bydureon, it's also FDA approved as an adjunct to diet and exercise to improve glycemic control in patients with type 2 diabetes. You initiate it at a 2 milligram subcutaneous dose every week without regards to meals, and you administer immediately after the dose is prepared. The most common adverse effects associated with exenatide are nausea, diarrhea, vomiting, constipation, injection site pruritus, injection site nodules, and dyspepsia. And there is that black box warning for the increased incidence of thyroid C cell tumors and medullary thyroid carcinoma in rodents. And its use contraindicated in patients with a history of medullary thyroid carcinoma or in patients with multiple endocrine neoplasia syndrome type 2. What's important to note here is that this adverse effect of injection site nodules, it has to do with the biochemical makeup of the drug. So the exenatide ER is an encapsulation of exenatide within biodegradable microspheres, which results in a slow, gradual release of exenatide. And its peak plasma concentration is week 2 and week 6 to 7. The elimination half-life is 2.4 hours once released, and it could be administered at any time of the day, independent of meals. It has a larger effect on your fasting glucose than your postprandial glucose. And the injection site nodules, like I mentioned, are more common with the ER formulation. But with this drug class, as opposed to the intermittent release exenatide, the nausea was less and weight loss is comparable. It comes available commercially as a 2 milligram pen, and it does not require separate prescription for pen needles. So exenatide ER was studied in the Excel trial in 2017. It was a double-blind, placebo-controlled trial of patients with type 2 diabetes with a population size of 14,752. Exenatide ER added to standard therapy versus placebo was the intervention they made. And the primary outcome was your composite of death from cardiovascular causes, non-fatal myocardial infarction, or non-fatal stroke. And the results were that it was statistically significant for non-inferiority, but the P was 0.06 for superiority. So similar to lixacenatide, this exenatide does not have that FDA indication for cardiovascular benefit in type 2 diabetic patients. Next up is liraglutide, brand name Victoza. It's FDA approved as an adjunct to diet and exercise to improve glycemic control in patients greater than or equal to 10 years old with type 2 diabetes. And it also has this FDA indication to reduce the risk of major adverse cardiovascular events in adults with type 2 diabetes and established cardiovascular disease. The recommended dosage is that you initiate patients on this 0.6 milligram daily dose for 1 week, and then you increase it to 1.2 milligrams daily for 1 week. And if a patient requires additional glycemic control after the 1.2 milligram, then you can increase it to 1.8 milligrams daily. The most common adverse effect is your nausea, diarrhea, vomiting, decreased appetite, dyspepsia, and constipation. And it has that black box warning associated with thyroid C cell tumors, as well as the medullary thyroid carcinoma. So the peak plasma concentration of Victoza is 8 to 12 hours. Its elimination half-life is 13 hours, and it can be administered at any time independent of meals. It has a larger effect on fasting glucose than it does on postprandial glucose. What's unique about this drug is that it can cause increase in heart rate, about 2 to 3 beats per minute. So let's say a patient comes in and they're tachycardic or their baseline is at the upper limit of normal, then it's something to look out for prior to initiating therapy. Commercially, it's available as 18 milligram per 3 ml pen, and a separate prescription is required for the pen needles. So liraglutide was studied in the LEADER trial in 2016. It was a double-blind, placebo-controlled trial with a patient population of 9,340 patients. The intervention was liraglutide versus placebo, and the primary outcome was your first occurrence of death from cardiovascular causes, non-fatal myocardial infarction, or non-fatal stroke. And the result was the primary outcome was statistically significant for superiority, as well as lower rates of nephropathy were found, which are statistically significant in the liraglutide group as opposed to the placebo group. What's good to note here is that the death from cardiovascular causes was statistically significant in these patients, but the risk of non-fatal MI and non-fatal stroke was not significant. Next up is dulaglutide, which is your brand name Trulicity. It's FDA approved as an adjunct to diet and exercise to improve glycemic control in patients with type 2 diabetes. And it also has that indication for risk reduction of major cardiovascular events in adults with type 2 diabetes who have established cardiovascular disease or multiple cardiovascular risk factors. So it's recommended to initiate the dose at 0.75 milligrams once weekly, and then you can titrate it up to 1.5 milligrams once a week. And the most common adverse reaction is your nausea, diarrhea, vomiting, abdominal pain, decreased appetite, as well as that black box warning for thyroid C-cell tumors, as well as your medullary thyroid carcinoma. The peak plasma concentration of Trulicity is 48 hours, so it's a long-acting drug. Elimination half-life is 4.5 days for the 0.75 milligram dose, as well as 4.7 days for the 1.5 milligram dose. And you can administer it at any time of the day. It's just preferred to be administered the same day each week. And it has greater effect on your fasting glucose than your postprandial glucose. So that's something that can help patients that are struggling to control their fasting glucose. It's available commercially as a 0.75 milligram pen, as well as a 1.5 milligram pen, and it does not require a separate prescription for pen needles. Now getting into the study, so dulaglutide was studied in the REWIND trial in 2019. It was a double-blind, placebo-controlled trial of patients with type 2 diabetes and high cardiovascular risk. The patient population size was 9,901 patients, where they intervened with dulaglutide added to their baseline therapy, as well as placebo. And the outcomes that they studied were composite of non-fatal myocardial infarction, non-fatal stroke, or death from cardiovascular causes. And the results were statistically significant for the primary outcome. What's good to note here is that the non-fatal stroke was statistically significant in these patients with a P of 0.017. Next up is semaglutide, brand name Ozempic. This is the injectable semaglutide. It's FDA approved as an adjunct to diet and exercise to improve glycemic control in patients with type 2 diabetes. And it also has that cardiovascular benefit indication from the FDA. You dose it at 0.25 milligrams once a week. And then after 4 weeks, you increase it to 0.5 milligrams once weekly. And then you can titrate it up to 1 milligrams if additional glycemic control is needed. The most common adverse effects are your nausea, diarrhea, vomiting, abdominal pain, and constipation, and your black box warning for increased incidence of thyroid C-cell carcinoma, tumors, and medullary thyroid carcinoma in rodents. And the contraindication in patients with the history of MTC, as well as multiple endocrine neoplasia syndrome type 2. So the semaglutide is available. It's as 1 milligram per dose or 0.25 milligram to 0.5 milligram per dose pen, and it doesn't require an additional prescription for pen needles. Its peak plasma concentration is 1 to 3 days, also a long-acting drug. Its elimination half-life is 1 week, and its administration is any time of the day without regard to meals, just ensuring that the patient takes it the same day each week. And it consistently reduces both your fasting and your postprandial glucose. So semaglutide, Ozempic's cardiovascular benefit was studied in the SUSTAIN-6 trial in 2016. It was a double-blind placebo-controlled trial of patients with type 2 diabetes with a patient population size of 3,297 patients. The intervention was semaglutide versus placebo, and the primary outcome of composite of death from cardiovascular causes, non-fatal myocardial infarction, or non-fatal stroke. And the primary outcome was statistically significant. The non-fatal stroke aspect of the primary outcome was statistically significant, whereas the CV death and non-fatal MI was non-significant. The rates of nephropathy were lower in the semaglutide group, 3.8% versus 6.1%, which was statistically significant. What's important to note is during this trial, the rate of retinopathy complications were higher with semaglutide compared to placebo, which was statistically significant. So that's something to look out for, especially if you have a patient that's diabetic that has a baseline retinopathy. Ozempic might not be the ideal drug. Although if you look further into the studies, they associated it with poor glycemic control prior to initiation of the trial. So it's kind of up in the air or whether or not it's recommended in patients with retinopathy or not. Recently, oral semaglutide, brand name Rybelsus, was developed. It was FDA approved on September 2019 as an adjunct to diet and exercise to improve glycemic control in type 2 diabetes. It's important to note that the FDA approval is just for glycemic control and not for the cardiovascular benefit, although they're the same generic drug. It's initially recommended as a 3 milligram dose where you take it at least 30 minutes before your first meal of the day or the first beverage of the day or any other medication you might be taking. And what's unique about this medication is that you're not supposed to take it with more than 4 ounces of water. So that's a key counseling point for patients. After 30 days, you titrate it to 7 milligrams once daily. And if further glycemic control is needed, you can titrate it to 14 milligrams as well after 30 days. The most common adverse effect is your nausea, abdominal pain, diarrhea, decreased appetite, vomiting, constipation, and it does have that black box warning in regards to thyroid cell tumors and your medullary thyroid carcinoma. The 30 minutes, the 4 ounces of water has to do with the unique mechanism that they did in order to develop the drug. It has to do with the absorption. If a patient takes the medication with more than 4 ounces of water, then the trials indicated that the absorption would be poor. So Rybelsus, generic oral semaglutide, was studied in the Pioneer 6 trial with a patient population size of 3,138 patients that had high cardiovascular risk. And the intervention was oral semaglutide versus placebo. It's important to note the dose of the oral semaglutide was the highest dose of 14 milligrams once daily. And the primary outcomes was composite of death from cardiovascular causes, non-fatal MI or non-fatal stroke. And it was found to be that the oral semaglutide was non-inferior to placebo for the primary outcome, where MACE occurred in 4.8% of the placebo group and 3.8% of the oral semaglutide group. But it did not indicate superiority. That's why that FDA indication is not there for cardiovascular benefit in patients with type 2 diabetes. So this is just a summary slide. The FDA approved indications for GLP-1 receptor agonists. So as you can see, all the GLP-1 receptor agonists are approved for glycemic control in patients with type 2 diabetes, but only 3 of them, the liraglutide, your semaglutide subcutaneous, as well as your dulaglutide, are indicated for this cardiovascular benefit. And the benefit data suggests that semaglutide has a better cardiovascular event reduction than liraglutide, which has a better cardiovascular event reduction than dulaglutide. And this is just a dosing summary. So like I mentioned previously, each GLP-1 receptor agonist has varying initial doses and varying titration doses, and the onset effects vary per drug, as well as the dosing time. So that's key for us as pharmacists to understand, especially if we're in settings where we have to counsel patients that are diabetics that might be initiating therapy. It's key for us to know how the drug works, how to titrate it appropriately, how to initiate a patient on it, and what key counseling points to look out for. And this is just a summary slide of the side effect profile. So the rates of nausea, vomiting, and diarrhea are significantly high in patients that are initially started on GLP-1 receptor agonists. And then normally when a patient is accustomed to it and they've been dose titrated, Once they're stable, the rates are significantly lower. What I wanted to point out here was the exenatide once weekly medication. As you can see, due to that encapsulation of the exenatide pharmacologically, it has high rates of injection site reactions as opposed to the other GLP-1 receptor agonists. The rate in exenatide extended release is 10 to 22%, as opposed to other drugs, the other GLP-1 receptor agonists, which are very minimal. So that's something to look out for, and it's a key counseling point for a patient, that might be initiating therapy on this extended release exenatide. So managing GI side effects. So you can consider a slower dose titration or temporarily reducing the dose. You should counsel patients to stop eating when they feel full. You can start a patient on a lower dose of metformin if it's applicable, obviously with prescriber approval. And you can also use antiemetics during the titration period if required, and obviously with prescriber approval. So this is just a chart which shows the clinical effects of GLP-1 receptor agonists in type 2 diabetes. So glycemic control is the primary goal of anti-hyperglycemic therapy. The mean change in A1C reported in clinical studies from 24 to 52 weeks duration is shown in this figure. And the studies of GLP-1 receptor agonists used alone or in combination with oral anti-hyperglycemic therapies, the mean change in A1C range from negative 0.8 to 1.7 for exenatide twice a day, negative 0.8 to negative 1.5% for liraglutide, 1.28 to 1.8 milligrams once daily, negative 0.6 to negative 0.9 for lixisenatide once daily, negative 0.6 to negative 0.9 for albiglutide, 30 to 50 milligrams q weekly, which is recently taken off the market, 0.7 to negative 0.16 for dulaglutide, and negative 1.3 to negative 1.6 for exenatide. So all of these GLP-1 receptor agonists have an effect on your baseline A1C reduction, which is obviously a very important thing for patients in type 2 diabetes. And then this is a figure that shows the clinical effects in body weight reduction with GLP-1 receptor agonists. In clinical trials of once daily or twice daily GLP-1 receptor agonists, mean changes in body weight were negative 2.1 to negative 2.9 kilograms for monotherapy and plus 0.3 to negative 3.6 in combination with oral anti-hyperglycemic therapies. In trials of weekly GLP-1 receptor agonists, which are your exenatide ER and your dulaglutide, the mean body weight changes were negative 0.7 to negative 1.6 for monotherapy and plus 0.3 to negative 3.1 kilograms in combination with oral anti-hyperglycemics. Weight loss in patients receiving GLP-1 receptor agonists is thought to occur as a result of like this delayed gastric emptying, as well as the increased satiety that these patients have once they're initiated on GLP-1 receptor agonists. And this is just a summary slide of the studies conducted to evaluate the cardiovascular safety of GLP-1 receptor agonists. In the presence of standard treatment, both liraglutide and semaglutide in their respective studies showed superiority in cardiovascular benefit versus placebo. Both liraglutide and semaglutide showed statistically significant differences in the hazard ratio for the composite endpoint of MACE. Liraglutide additionally showed a decreased risk for acute myocardial infarction and CV death, and semaglutide showed a decreased risk for stroke. But what's key to note is that in the semaglutide study, there were diabetic retinopathy adverse events, as 50 patients on semaglutide had retinopathy complications. And although it might be related to the poor baseline metabolic status, it's just something to keep an eye out for. And cardiovascular safety outcomes in lixisenatide and exenatide ER indicated that there was no, they were safe, but there was no additional cardiovascular benefit from those drugs. And there's another drug class that works on incretins, known as your DPP-4 inhibitors. They work by suppressing the enzyme DPP-4 that normally degrades endogenous GLP-1 receptor agonists, and therefore increasing the concentration of biologically active GLP-1. DPP-4s have not been shown to be associated with any cardiovascular benefit, and head-to-head clinical trials between GLP-1 receptor agonists and DPP-4 inhibitors showed GLP-1 receptor agonists consistently improved glycemic control and decreased weight, more so than the DPP-4 inhibitors. And the question comes, like, would it be suggested to use DPP-4 inhibitors in conjunction with GLP-1 receptor agonists? But current guidelines prove that synergistic effect it doesn't provide a synergistic effect when used in combination, and it's not cost effective for the patient. So the current recommendations go against using a combined incretin therapy. GLP-1 receptor agonists are the preferred drug out of these two. This leads us into our third question. So TD is a 51-year-old male with type 2 diabetes who has been using metformin and basal insulin. He has been unable to reach his targeted HbA1c, and the physician is considering combination injectable therapy with the GLP-1 receptor agonist. Prior to initiating therapy with the GLP-1 receptor agonist, what should this physician evaluate? So A, history of pancreatitis, B, kidney function, C, concurrent medications, or D, all of the above. Correct. Yep. So D, all the above is correct. When initiating therapy, you want to assess whether a patient has a history of pancreatitis because it's contraindicated, and GLP-1 receptor agonists. You want to assess their initial baseline kidney function because certain GLP-1 receptor agonists are contraindicated with poor EGFR, and you want to assess their current medications because let's say a patient is on DPP-4 inhibitor, you don't want to initiate a GLP-1 receptor agonist because there's no synergistic benefit. So applications of this drug class beyond diabetes. So liraglutide is approved for the treatment of obesity with a different marketed brand name known as Saxenda. It's indicated, FDA approved, as an adjunct to diet and exercise in patients with a BMI greater than equal to 30, or a BMI greater than equal to 27 when the patient has greater than or equal to one weight-associated comorbidity, such as hypertension and dyslipidemia. The dosing of this is very key. You initiate the patient on 0.6 milligram once daily for 1 week, and you increase it by 0.6 milligrams daily at weekly intervals to get this targeted dose of 3 milligrams. The 3 milligram dose is much higher than the associated diabetes indication for liraglutide, which is like 1.8 milligrams max. So that's something key to look out for, especially if you're verifying orders. You don't want to confuse the two. And semaglutide similarly is approved for the treatment of diabetes at a higher dose than for the management of type 2 diabetes, and it's marketed as a separate brand name, Wegovy. It's an adjunct to reduce calorie diet and increase physical activity for patients that are obese with the BMI greater than or equal to 30 or 27, greater than or equal to 27 in the presence of at least one weight-related comorbidity, like hypertension, type 2 diabetes, dyslipidemia. And the dosing frequency of this is very unique as well. You initiate patients on 0.25 milligram injectable, and then from week 1 to 4, and then from week 5 to 8, it's 0.5 milligrams once weekly. Week 9 through 12, it's 1 milligrams once weekly. 13 to 16, it's 1.7 milligrams once weekly. And week 17 and thereafter, it's a 2.4 milligram dose, which is significantly higher than the type 2 diabetes dose that we commonly see. And semaglutide, brand name Wegovy, was studied in the semaglutide treatment effect in people with obesity step 1 trial in 2021. It was a randomized parallel placebo double-blind trial, and the intervention was titrated dose of semaglutide up to 2.4 milligrams versus placebo. And the co-primary outcomes were mean change in body weight and weight loss from baseline of 68 weeks. And the results were statistically significant. There was a negative 14.9% change in body weight in the semaglutide group versus negative 2.4% in the placebo group. And for the co-primary outcome of weight loss of 5%, negative 86.4% patients in the semaglutide group compared to 31.5% patients in the placebo group, which is also statistically significant. So the clinical applicability. So we're just going to discuss this patient case. HH is a 45-year-old male with type 2 diabetes, diagnosed 6 months ago with hypertension, hyperlipidemia, history of MI, status post PCI in January 2019, and obesity. His BMI is 31. The patient's HbA1c at diagnosis was 9.5, and he was initiated on metformin, 500 milligrams twice a day, which is increased to 1,000 milligrams twice daily. Today, the patient presents for follow-up. Patient reports that he's adherent to his medications and has made significant lifestyle changes since his diagnosis of type 2 diabetes. His current medications includes the metformin 1 gram twice a day, clopidogrel 75 milligrams once daily, aspirin 81 milligrams once daily, your atorvastatin 80 milligrams once daily, and your lisinopril 10 milligrams, as well as your carvedilol 12.5 twice a day. The vitals today are blood pressure of 120/70 and pulse of 70. His current labs, HbA1c is 9.0, and his renal function and liver function are within normal limits, negative for albuminuria. So what are the next steps for the management of patient's diabetes? So like the patient factors you want to consider is that this is a young and newly diagnosed diabetic. His A1C goal is less than 7, according to the guidelines. He's adherent to his medications, namely the metformin, and he's attempted lifestyle modifications. And he has a history of ASCVD due to that prior myocardial infarction. And it's good to note that he's also obese. So when you're assessing for potential add-on therapy, there's a number of factors that you should consider. You want to avoid a sulfonylurea, given that the patient is obese and you would like to promote weight loss. You want to choose an agent that has proven CVD benefit, given his history of ASCVD with that myocardial infarction. You want to choose an agent that will help achieve A1C reduction that the patient requires. So considering all these factors, the ideal medication of choice on top of his metformin and lifestyle modification would be a GLP-1 receptor agonist, such as with proven CVD benefits, such as your semaglutide, your liraglutide, or your dulaglutide, or an SGLT2 inhibitor, such as your empagliflozin or canagliflozin, with proven CVD benefit. And then furthermore, you would want to consider patient factors such as preference for oral drug versus preference for a weekly injectable, the side effect profile of the drugs, and overall cost for the patient. And just like some acknowledgements here, I just want to I'd like to thank Amanda, Caesar, Joe, and Diane for their help making this presentation. And that's the conclusion of my presentation. Any questions at all? Okay. Yep. All right. Thank you so much, everyone, for tuning in. I hope that it was an informative talk and that you learned more about GLP-1 receptor agonists and you can apply it in your clinical practice. If you have any additional questions, please don't hesitate to email me. And thank you again for your time and joining in. Have a good day.